Welcome to the Human Factors and Ergonomics Hub, a series of educational podcasts that showcase the connection between human capabilities and good work design, brought to you by the Human Factors and Ergonomics Society of Australia. What a privilege it is to be back with all of you on the HFE Hub. I'm Sharon Todd, and today I'm chatting with Professor Robyn Clay-Williams. She leads a research program at the Australian Institute of Health Innovation at Macquarie University in the field of human factors in healthcare. Over a career spanning nearly 45 years in aviation and healthcare, Robyn has worked extensively to develop and evaluate systems to make them fit for purpose and easier to use. Robyn, it's such a pleasure to have you on the HFE Hub. Thank you for joining me.
Thank you.
I know that you've been in the industry for a long time and you've got a really interesting background. So maybe you could tell us a little bit about your background and how you became interested in human factors and ergonomics.
Sure. Okay, thanks, Sharon. So I guess I probably first became interested when I was in the Air Force. So I joined the Australian Air Force straight out of school and I spent 24 years in the Air Force. I was a pilot for 15 of those years and a test pilot for the last 10. And it's when I became a test pilot that I got interested in human factors, because test flying really is human factors. You're looking at testing an aircraft to make sure it's fit for purpose. So you want it to be able to fly whatever mission it's meant to fly. And the sort of tools and techniques you use are all the tools that we use in human factors. I just didn't know that that's what it was at the time. So it wasn't really till I left the Air Force, I guess, that I realised that it was human factors, tools and techniques. But yeah, that's what it was. So
what are you doing with yourself these days?
Right. So I left the Air Force in the mid-2000s and I've joined healthcare, and I'm now a health services researcher. So I'm a professor of human factors at Macquarie University in Sydney, and I work in the hospital system, mostly around emergency departments, looking to try and design emergency departments and design care so that it's a better fit for the people who use it, both the clinicians and also the patients.
So does the Department of Health approach you? How does that work?
No, no, we approach them. So, because I'm in a research institute, so I'm in the Australian Institute of Health Innovation, which is a health services research institute. Most of our funding comes from government funding. So we call them Category 1 grants. So the National Health and Medical Research Council or the Australian Research Council provides most of our funding. Also the MRFF, so the Medical Research Future Fund, are probably the main things. We do have some contract work from the health system, but they tend to be smaller projects. So for us to do a large project, you're usually talking between $2 and $5 million, and the sorts of contracts that we get from government tend to be more $500,000 or so.
Okay, so you approach them. So tell me how that really works.
Yeah, so because we work with them, you get a feel for the problems that they've got. So it's sort of an ongoing process. So when you first start, you're working with other people and you learn from them. But once you're starting your own projects, you've already got contacts in the health system that you've been working with, and you've got a bit of an idea of the sorts of issues that they want. So what you do is you just talk to them and say, okay, this looks like something that I think we can help you with. What do you think? And then you put together a proposal. And then you put that proposal into a grant application call. And if you're very, very lucky, so it's only about 6 to 9% of proposals are successful. But if you're very lucky, you're successful and you get the funding to then do that project.
Okay. So you've indicated to me that you've been working on a project for emergency departments with vulnerable, underserved patient cohorts. Tell me about that.
Yes, I have. So this is the main project I've been working on for the last 3 years, and we've still got 2 years to go of that project. So emergency departments are really set up for a one-size-fits-all. They're really just a throughput system. And they don't really work for a lot of the people that use them. So they don't work for older adults, for example, especially people who are older and fragile. So, maybe over 85, or they might have come from a nursing home. They don't work for people who are culturally and linguistically diverse, because they may not speak the language and they may not understand how the system works. They don't work very well for people with a mental health condition. They're really designed for people with a physical emergency or a physical problem. They don't work very well for people with a disability, unfortunately. They're not designed to cope. I mean, they've got the same sort of basic disability allowances that you have in any public building, but the way it's set up it's not set up well for people with a disability, particularly if they're unwell. And it's not set up well for Aboriginal and Torres Strait Islanders, people who are Indigenous. If they're going to die, they would like to die on country. They don't want to die in a hospital or in an emergency department. And then the emergency departments are not really well set up to be culturally safe and to really understand the needs of that community.
So tell me how you identified some of the needs of these groups.
Oh, we talked to them. So it's sort of a multi-phase project. So the first thing that we did, we've got a team of 10 people. And the first thing we did was we went into the emergency departments and we just sat there for, a number of shifts just to have a look and see, well, what's happening? Because you can talk to people about what they do and they tell you what they do, but they don't always see the things that you see if you come in as an outsider. So we just come in and we sit there, on and off over a couple of months. Until we sort of get a feel for what they're doing and we notice things. And then we start interviewing people. So we interview the doctors and nurses that work there. We interview some of the other people that work there that don't always get interviewed. So, like the person who moves the patients around, the clerk who registers the patients in, the cleaners, the security people, and the patient experience coordinators who sit in the waiting room and can help patients. So we talk to all of those people with interviews, and then we analyse the interview data and we have a look at what we call touch points. So we talk to the patients. So we talk to the patients from all those different groups. So for this particular project, we did interviews with 50 patients, or close to 50 patients from each of those 5 groups I spoke about. And there's sort of artificial divisions too. There's a lot of crossover. Like you can get obviously an Indigenous person with a disability or an older person with a mental health concern. So, but people, we tried to put them into one of those 5 groups and interviewed them. And then we analysed the interviews and we looked at things called touch points. So where is it that the patients have a concern or having difficulty, where the clinicians are also having a concern or having a difficulty? And that's the area where you can start co-designing because they're both motivated to do that. And then we go in and we start co-design.
That's really clever. These touch points are the intersection between 2 groups of people that have similar needs, or different need, but they're trying to operate.
Yeah.
Just maybe talk about that.
Yeah, okay. So I could give you a couple of touch points for different groups. So the culture and linguistically diverse group, for example, we found 2 touch points with those groups. Now, some of this sounds really obvious, but things aren't always as obvious as they seem. So the first one was to do with communication, which you would think, yeah, that sort of is obvious. But it's a bigger issue than you would think. So someone comes into the emergency department and they might have been speaking English for a long time. They speak English down the shops. They speak English, to their friends and family. But when they're ill or they're really badly injured, their cognitive capacity is really often restricted, especially if they're in pain or something like that, and their language skills just go out the window and they're back to their home language. So communication was an issue because they would come in and they would say, do you need an interpreter? And they go, no, because normally they don't. But of course, then they wouldn't, they'd lose a lot of their English. And also a lot of the medical terminology, doesn't necessarily not easy to understand. The other touch point with the culture and linguistically diverse group, though, was health system literacy. So people talk about health literacy. So if your health literacy is not so good, then you don't do so well because you don't really understand health and how to look after yourself and things like that. But the culture and linguistically diverse group actually have really good health literacy. In some cases, they've got better health literacy than the average non-CALD Australian, but they don't have health system literacy. So if you take people that come from China, as an example, they don't have primary care in China. They don't have GPs. So when they come to Australia, if they're unwell, they come to the emergency department because that's where you would go in China if you were unwell. Whereas for us, we want you to go to primary care first. We only want you to come to the emergency department if you're really unwell and you haven't been able to access care anywhere else. So that's just two examples from one of the cohorts. But usually we had 2 or 3 touch points for each of the cohorts. And it's a good place to start your co-design, because you really need people to be able to empathise with each other if they're going to work together. And because people, often patients have not had a good emergency department experience. They've maybe waited a day or 2 days, sometimes longer, and they haven't necessarily felt they've got the care that they needed. They're not always in a good space or a good mind to want to collaborate with clinicians. So starting with these touch points is sort of a thing that everyone can rally around and talk about, rather than, just talking to each other. And it also helps them talk about the issues that are applicable to a wider group rather than just their own personal issues. A lot of people don't necessarily want to talk about their personal issue. It's a privacy situation. So it's good to be able to rally around like some general points that are in common.
So you talk about the co-design starting at that point. So what do you do then at that point?
So co-design, okay. So it depends. So you really need, when you get the patients and the clinicians in the same room, you need a level playing field. And you normally don't have that if you just bring them straight in, because the doctors sort of, there's a very much a hierarchy in the health system. Like if the patient's sick, they don't really have a lot of power. The doctor's got all the power. So you can't really just bring them in. So we did it in 2 different ways. So with some of the groups, we did co-design with the patients first. So we did a couple of sessions with them first, so they could come up with their ideas and talk about things before we brought the clinicians in, and then we would bring the clinicians in. Some of the other groups, we did them together, but we started the patients differently. So to give you an example, with the mental health group, we had some consumer participants who had a lot of anxiety, and they'd had some quite bad experiences in the ED. So an ED experience for someone with anxiety can be really distressing, because EDs, there's a lot of noise and light, and and they're made to sit there for a long time. So what we did was we brought them in 45 minutes early, and then took them to a coffee shop. And they all got to know each other and have a coffee and everything, and just got to relax. And then we brought them into the co-design room, and the clinicians, we didn't do that. We just brought them straight in. But it gives them sort of that level thing. And we usually start them with an activity that's non-related to health. One of them was, Brisbane wants our opera house. How can we deliver our opera house to Brisbane? So you just get them doing something that's totally non-related, that's a bit silly, and hopefully they can start laughing about it. We do things as well too, like to keep them just so they're not nervous. So with the mental health group, for example, we had a little Play-Doh thing for everybody. So the clinicians as well, not just the patients, but they could actually sort of play with that and just keep their hands busy, and it's just a way of alleviating a little bit of their anxiety.
And so then once you've done the icebreaker, is the idea that then they talk together about solutions or problems and solutions?
Yeah, so what we usually do is we usually start with their needs, so what are your needs at both sides? Okay, and then now that we know what the needs are, let's have a look at some of the solutions. And then once we've got solutions, we try and group them into things, because we want them to come up with even weird, out-of-the-window solutions, because often those solutions which people would think, well, you can't do that, there's often something behind it that you could do. You could, because there's a sentiment behind it that you could address. So once we get all the solutions, we sort of start to group them into things that, at one end of the scale are really expensive, at the other end are really cheap, things that might work for lots and lots of people or might only work for a few people, things that are already being done. So there's a surprising number of things that are being done or are available in the ED that the patients don't know about. So that's another one too. So you just sort of group them into different things, and then you decide together the ones that are sort of the most viable, that work for the most people, that are, reasonably affordable. So there's a high likelihood we're going to be able to actually do something about it. We start working on those, and you just pick one at a time and you start talking it through, like, how are we actually going to make this happen?
So tell me about one of the groups that you've been working with and some of the solutions or problems and solutions that you came up with.
One of the groups was older adults. With the older adults, we actually worked with the carers. So we interviewed the older adults, but we ended up working with the family members because these people can't travel, and the co-design sessions go for like 3 hours, and they have to go for that long because you've got to actually puzzle things out. But for someone who's in their late 90s or mid-90s, like, they can't sit there for 3 hours and go through all this. So we worked with family members or carers, and one of the solutions that we looked at, there's a few solutions we looked at, but one of the solutions we looked at was for adults who are nearing the end of their life. So in the last 6 or 12 months of life, there's not a lot of benefit in people coming in and having everything done, tube down the throat, chest compressions and all that sort of stuff, because, they're not going to be 100% well, and they're probably going to have a significant disability at the end of it. So we talked to them about what they needed, and what we found was they really just needed dignity and choice were the two things they wanted. And when you hear someone go, well, I want everything done, usually it's a family member. It's not usually the older adult themselves. So we talked about what we could do about that, and we're now designing. In fact, we're just putting a business case together for it, for a process where when older adults come in, they can be taken aside and they can have a choice of what they want, rather than immediately just all action and very medicated without consultation. So that's an example. We've got physical examples, so we're looking to try and do things in the waiting room. So some things we can't solve easily. So we can't immediately make it quicker to get through the ED. It's a lot of it is a function of the things that the doctors have to do. So people come from another country and they go, well, like, in my home country, I can get through the ED in 30 minutes. What's the problem here? In reality, you could get through it in 30 minutes here too, but we wouldn't be following all the processes that we follow, and we wouldn't be doing all the safety things that we do. All of that documentation and making sure it's safe takes longer. So people are probably going to be there for a few hours. But what can we do about that? So we're looking at a couple of things. This came out of the mental health one, where they were really just highly anxious. Two things. One of them is bringing some volunteers in, and they've already brought volunteers into the ED as a result of this, and we're going to gradually move them to the waiting room. They want to start them in the ED first, but these are volunteers who have a clinical background, and they often speak a number of languages, and they'll have a name tag with the languages they speak on their name tag, and they'll be able to do things like just sit with somebody, because the doctors and nurses don't have time to do that. They can't just sit. And sometimes someone who's very anxious just needs someone to just sit with them, and that's it, and it's enough. So that's one thing. And another thing that's a practical thing is we're looking at whether we can hand out things like they do in an aircraft. You know how you get your little package that's got your eye patches and your earplugs and all that sort of thing. So just things that people can put on to dampen down some of the noise and the light and things like that. So we're looking at whether there's a possibility of doing that, and to make things like blankets and pillows more accessible so that people can get access to them easier.
I obviously have a health background, and I'm always thinking about things that really annoyed me about ED departments that you've either worked in or been to as a patient yourself. And seating is always one of them, in terms of the seats are always supremely uncomfortable. And I've always thought that's really to get you to get up and go home. But if people are waiting a long time, did that kind of thing come up in terms of people's comfort?
Yeah, it did. And there's, as you say, they're not expecting people to wait. So the seats are designed for a medical waiting room where you might wait half an hour or an hour. And as you said, they're really uncomfortable. And not only that, but in some of the EDs, so in one of the EDs we were working, it's a new ED, and the seats were architecturally designed, and they've got low backs, and they found that people were falling off the back of them and getting head injuries, right? So they were designed for aesthetics and not function. So that's the first one. The other thing they did was the ED was bigger, so they said, well, we won't need as many seats in the waiting room. Which is not an understanding of flow dynamics. Obviously, you actually will need the same number or more. But anyway, so the seating is a big issue, and we're looking at whether we can do something about that. the sorts of things we're exploring are the ability to have some pods in there where people can, if they're there a long time, they can sort of be by themselves and maybe get some rest while they're waiting. We're looking at more comfortable seating, but it's quite difficult. There's trade-offs with it, as you would know yourself as a healthcare professional. There's an infection issue. It's got to be easy to clean. You've got to be able to see the patients. So the patients are monitored, through windows to a certain extent, and you've got to be able to see what they're doing. So there's a few trade-offs with it, but hopefully we'll be able to do something with the seating, I hope. We're talking to one of the geriatricians we were talking to with the older adults was saying, more than 50% of the patients that come in are older adult. Why don't we design the EDs for older adults and then they'll work for everybody? So the floors need to be, so that someone could fall on the floor and they don't break a hip, for example, and things like that. And the systems for calling people. So, an older adult comes to the ED, they wear hearing aids. They don't want to bring them to the ED. They're worried they're going to lose them, which is probably valid. So a lot of them will leave things like their hearing aids at home. So they turn up. They don't hear very well. The way people get called in is someone just comes to the door and goes, Mrs. So-and-so, and of course they don't hear, So we're just looking at that sort of thing, seeing if there's other ways we can do it, The consumers want it to be more like an airport, having lots of, or like Services New South Wales, where you come in, you register, you get a tag with a number on it. You can see how you're going with your number on a screen. If there's delays, they tell you about delays. When they want to call you, they either buzz your phone and you get a message that you need to be called now, or they give you a buzzer that you hold on to. So that, we're trying to maybe bring some of those ideas in.
That's a really great idea because let's face it, people really want to maybe go walk and grab a coffee, and in some hospitals you can do that, in others you can't. And if you've missed your call, then you're in serious trouble. But the idea of the tag is great. And let's face it, the healthcare system has the patients numbered anyway. They've got a screen that they're running. They can just somehow share the data without, breaching.
These things could be done. We're also looking at a check-in kiosk as well, so people can actually check in via a kiosk so that they don't have to wait for a clerk. And the check-in kiosk can actually provide a QR code to information so that if they want more information, they can just click on the QR code. So, there's technology has a lot to offer, I think. But early days, and it's expensive is the problem, of course.
So have you had some great successes?
Not yet, because it's too early. This is one of the problems too, is that research is very slow. So change is very quick and research is slow. And even while we've been doing the project, they keep changing things on us. So because we've been talking to the senior clinicians all the time, they go, oh, that's a good idea. And next thing you know, that there's some change that's sort of, so it's quite difficult. I think for us, the success will be measured in the fact that we're actually getting traction with people. And I think there will be change. So people are actually listening, they're listening to what the patients want. And I think they're going to act on it. Well, they have acted on it. I just wish they'd wait for us so that we can, evaluate it in our nice, robust way.
The flip side of that question is, what are some of the greatest challenges? Obviously, money is one of the things that always comes up. Yeah.
Money is a challenge. The funding system of our health system's a challenge. The way the fundings works for a lower socioeconomic area, it will drive people more to the ED, because now that we've got copay. So things like COVID and copay for general practitioners in combination. People say, if you've got a copay for the GP, you'll go to the ED. People don't do that. People don't go anywhere, and then they just get sicker. So they end up in the ED, and they end up in the ED when they're very sick. So the funding model is actually, we're seeing more sick patients in the ED than we'd seen previously. And they're not increasing the capacity, even though the population is increasing. So the area we're working in, I think it's like 10% population increase over the last couple of years, and the EDs have not changed at all. So, funding is probably the big one, I think.
What are some of the other problems that you've identified? And I guess you mentioned it earlier, which is culturally, in some countries, they will go to the ED, whereas here we want them to go to the GP. And I think there's been some work done before where they've tried to have GP clinics right near ED services. I'm just wondering if that's come up.
Yeah, so they actually do have. They've got an urgent care clinic sort of across the road. But you can't, once they're in the ED and registered and triaged, the ED has an obligation to treat them. They can't just turn them around and send them somewhere else. I think there's potential through the kiosk system to do that. So they could check in through the kiosk, and the kiosk could make suggestions of other places. Like if you don't want to wait for a few hours, if you go across the road, you'll probably be seen straight away. I mean, ideally what we want in the end is we want this to be able to be done from home on your phone. So you check in on your phone and they will say to you, look, it's going to be an 8-hour wait at the ED, or you could go to the GP. This GP who's open right now, they can see you at this time, or you could go to the urgent care centre and they can see you in 90 minutes or something. That's what we're looking for eventually, but we're still a little way from that technologically speaking.
One of the kids' hospitals in Sydney actually has a lounge, and what happens is you're triaged and then you're put into a lounge. Now, the lounge is monitored and they know where you are, and nurses are coming in and out and treating parents or not the parents, treating the children, but assisting, and there's more comfortable seating in there. Has that kind of thing come up?
Yeah, we need to. I would love to do the adult ED modelled on the kids' EDs. The kids' EDs are beautiful. They've got toys to play with. So even for adults, like, a colouring book, or is there something they could do to occupy them? Yeah, so I would love to do it like the kids' EDs. I went to a kids' ED in Brazil, and the lighting there, so within the waiting room and right through the ED, they had this really soft rainbow lighting that just cycled through, like pinks and blues and greens and yellows, just really slowly and really soft, but it was just beautiful. It would be easy to do stuff like that. Yeah.
Very calming probably as well.
Yeah, and that's what you want, because anyone who comes to an ED, even if they're not anxious before they got there, they're going to be anxious because by definition, you're not sure whether you're going to be all right or not, or whether your family member's going to be all right or not if they're the one that's sick. So everybody's anxious. So we really need to have ways of sort of just, calming it, I think.
So we are looking for the flight lounge, as you said.
Yeah, I think it'd be great.
Usually just searching for a coffee.
Yeah.
So obviously this project is a 3-year project and you're only part the way through. At this point, and it might be too early to ask this, but is there anything that you would have done differently if you were doing it again, or when you do it again?
Yeah, definitely. We've learned a lot through this. I would definitely start earlier with the patients, I think. Part of it's a function of it being a research project. So the first thing we had to do were a lot of literature reviews to look at what was the evidence, because you don't want to be doing things that have already been done somewhere else. It's just a waste of money. So you end up doing a lot of that searching. I think I would, that was 12 months worth. I would like to do all that before you start and just really start with the practical stuff. And probably the main one, I think. Just start earlier with the actual co-design and the practice.
And I imagine that's because you're trying to establish what people's needs are, and the needs are wide and varied depending on the cohort.
So some of it has to be done the way we've done it so that it's robust, because at the end of the day, we've got to be able to show that, because we're only working with 3 EDs. So we want to be able to sort of show what works here. So we're working with ACI, the Agency for Clinical Innovation, and they will actually move it out to the other EDs, but we've got to collect robust evidence about what works and what doesn't work so they can do that. So it does slow us down a lot, and it's a little frustrating, but necessary. So
I was going to ask what is next for you, but this project is still ongoing.
Yeah, it is. I know what I'd like to do next, though. So we did a small contract project with the Primary Health Network in the same area as the EDs, looking at integrated care for complex conditions, so like diabetes or long COVID or, some of the cardiac disease and things like that. And I think there's a really good project to be had combining the primary care with the ED, so that gap between the two, like how do they interact with each other? How do you move them seamlessly between the two? Can you do virtual care for the ED for some patients? Are you able to electronically link the data between the two so that people don't have to repeat everything all the time? Their health information is known to everybody. So things don't get missed and things like that. So that will be my next one. The other interface is the ambulance service. So we get a lot of ambulance ramping where the ambulance, you would know this from from your knowledge of the health system, but for people who don't, the paramedic has to stay with the patient until they're transferred across to the ED doctor. So what that means is that the paramedics are waiting with the patient for hours, and often you can have 10 or 12 ambulances lined up waiting for the patient to be taken. So I think there's some work to be done with that group as well, the interface between the ambulance and the hospital, and also between the ambulance and the patient. Is it possible for the ambulance to make an assessment at the patient home? And for some patients, they may not need to come in. Particularly the case for patients in an aged care facility, for example. There's a possibility they don't need to come in. Some of the patients with mental health condition, particularly anxiety, they could just be flagged and someone could come from the hospital to see them. So they could be seen at home. So, yeah, that's my next step. Need funding, though.
Yeah. So that sounds like a really interesting project, though. I can see how that would be, very useful. The kiosk idea is actually a good idea, just in terms of that means that you can make it multilingual. People can, like an ATM, and that's very clever.
So you can do the kiosk in all the languages that you want. The idea of and the kiosk as well with the QR code. It's not just information from the QR code. You can have a kiosk on your mobile, so you don't need to use the actual kiosk. You just have to QR code from it, and then you can fill the data in while you're sitting down and waiting. So I think it's a great idea. I've got a lot of people interested in doing it. We're putting a business case together for it. Again, it's expensive. So the kiosk itself, each kiosk, and you probably need two. You definitely need two because you need a backup. But if you can do it on your phone, you could probably get away with two. But the kiosks themselves are probably $150,000 each. But then it's $70,000 to $100,000 per year for the software and all that stuff. So that's expensive, and do governments want to pay that? I don't know. It's tricky because patient experience is not easy to cost. It's if the patient's happy, that it's really important, and I would say it's probably the most important thing is that the patient is not distressed and that they have an okay experience in the health system. But it doesn't count for any money. What's the cost associated with that?
Yes, that's a good question, isn't it?
Yeah, so it's very hard. We've found that when we're putting the business case together, trying to work out, so what's the benefit? There's lots of really obvious benefits to the patient, but when you're talking money, will they get through quicker? Probably not. Over time, I think, they'll be more aware of where they need to go, and there'll be maybe fewer people will go there. Over time, probably their health will be better because they won't have been through that stress and distressing period. But that's very hard to measure. It's over a long period.
The purpose of the kiosk, obviously, apart from just checking in, name details, I imagine that, is there, I'm going to use the term maybe a loose triage kind of?
Yeah, it can triage. It can triage. So you don't have to use it. Some people implement kiosks and don't use it for triage, but you can use them for triage. So it can do a basic triage. So it saves a little bit of time there. So three things really. So saving the check-in with the clerk, maybe at least starting the triage, which will be quite good, at least the initial parts of it. But also a centre for providing information. So if people need information, it would have the ability to, through a QR code, link you to a website. It's a bit like, when you go to your hotel room, you've got your big screen and all the buttons and, I'm really hungry. Where can I find food close to this place because it's 2 a.m? Oh, bang. Oh, okay, the nearest food place is, that sort of thing.
It's a great idea. The elderly clearly are not going to use it. So some of the underserved groups won't be using it.
A lot of them come with a carer though. So it's unusual for someone to come in who's elderly that doesn't have a family member with them. And the family members use it, and the CAL group would absolutely use it. A lot of them are very tech oriented. The only people we're not so sure about are the Indigenous Australians. not all of them have a mobile, for example. So, but yeah, that's remains to be seen. But
that's what research is for.
And you'd still have the clerk. Like, we're not talking about getting rid of everything. I mean, at the moment, there's usually 3 clerks there. You could probably get rid of at least one of them. That's a cost saving.
And realistically, you couldn't you? I mean, there's this kind of live chat concept that pops up, but you could also have a real person on the other end. You could be anywhere in Australia actually able to at least talk to you. So they do have that. So Northern Health in Victoria have a virtual ED. So if from anywhere in Victoria, you can zoom in like this and they will triage you and either call you an ambulance or tell you what you need to do. So there are places who do it. RPA in Sydney have got a type of virtual triage that can do it. There's a Health Direct number that you can ring, which will give you a phone triage that tells you, it'll just give you information. It's really good if your kids are sick. You can ring it and they'll say, what are the symptoms and things like that. It's nurses on the other end. And they'll give you advice about, quick, call an ambulance, or, look, I think you can wait till morning and see your GP tomorrow. So that's available too. But a lot of people don't know about it is the issue. I mean, even with the EDs, so all the EDs in Sydney, there's a website where you could get on that website and you can see how many people are in that waiting room. Now, the data's is not updated as much as I would like, but there still is information and it's relative. So if you live somewhere where there's maybe 3 different hospitals you could go to, you could have a look and go, okay, what's the busiest one? Okay, this one looks a bit less busy. I'll go to that one. But people don't know about that. And when we started this discussion, one of the first things you said was communication. So that's a really pivotal thing is getting that communication out to the public. Yeah, I didn't know about some of those services.
No, and we really found it out with the patients when we were doing the co-design, because they go, we really want this, and the clinicians are saying, well, we have that. It's like, well, it's not much good if no one knows about it. So, I mean, one of the things we've got to go in is go in and do an audit on some of these things and just see, like, what do they have and are they actually using it? Because, often they have things, but they're not being used as well.
Thanks for joining us at the Human Factors and Ergonomics Hub, brought to you by the Human Factors and Ergonomics Society of Australia, where human-centred design really matters. If you like this podcast, make us your favourite in your podcast app. We look forward to chatting with you next time.